أحب إن إحنا congratulate Dr. Shireen for the amazing scientific event. ودايما في نجاح as usual. Our presentation for today is short versus extended human chorionic gonadotropin stimulation test. We will start with our case presentation.
Our patient is a 4-month-old infant reared as a male, presented to our endocrinology clinic for assessment of atypical genitalia. His general examination was normal. His anthropometric measurements were normal. His genital examination revealed micropenis with a stretched penile length of 2 centimeters, which is below the 10th centile for age, with a small penile girth, with single urethral opening with normal position, underdeveloped scrotum, empty scrotal sac, but bilaterally 2 palpable swellings in the proximal inguinal region with an external muscularization score of 8. So after history and the general examination, we started according to the algorithm with the karyotype. Our patient karyotype was 46XY. Then we went for the ultrasound that revealed a bilateral inguinal testis with normal size, shape, and echogenicity with no Mullerian structures. Hence, our patient is 4 months old, so we assumed that our patient is in the period of mini puberty. We started to do his basal androgens and FSH and LH. His FSH was 0.18, which is low. LH was 0.01, which is also low. STH and cortisol were normal. Delta 4 androstenedione is less than 0.1. Total testosterone is less than 0.1, which is low. DHT was 1, which is also low. So at this point, our patient needs further investigation. Dr. Noha will tell us about his further investigations.
As highlighted importantly by Engy, that our patient in the golden mini-puberty period. But unfortunately, our patient has a quiescent axis. So we need to do a stimulation test, which is the HCG stimulation test. Our aim to detect the functioning testicular tissue and to evaluate the Leydig cell function in a pre-pubertal boy, and to evaluate if there is any testosterone biosynthetic defect. We have different protocols for HCG stimulation test. We have the short stimulation test and the extended one. And for the short HCG stimulation test, we have a different protocol, the single dose protocol and the 3-dose protocol. At that step, we have to ask ourselves, should we go for the short or the extended stimulation test? And to answer that question, we have to go back to the updated guidelines for the Society of Endocrinology for the guidance of values that we have to start with the standard short HCG stimulation test to evaluate the HCG in the Egyptian markets, as you see here. And we have different protocols. We have the 3 days stimulation protocol, which have a different methods for calculation, which the age-based calculation, it's according to the age. The patient is giving the calculated dose according to the age for 3 consecutive days. And we have the fixed dose calculation, which is ranging from 1,000 units per day for the infant and 1,500 units for the older age on 3 successive days. And this method is advised by the DSD. The time of the blood sample is based from the last injection, and the sample which include we do testosterone and DHT and androstenedione. And the other method is the 1-dose stimulation test, which is a single dose, 100 unit per kg or 5,000 unit per meter square. And we have the different timing and the same sample included. And the interpretation of this test is labeled as normal if the absolute testosterone concentration reached above the upper limit of the normal pre-pubertal range or rise twice the baseline. And we have different ratios for the differential diagnosis for androgen biosynthetic defect. So back to our patient.
After doing the standard short HCG stimulation test, our patient's total testosterone after stimulation is 0.13, which is less than the pre-pubertal cutoff value. DHT is 1.5. Delta 4 androstenedione is 0.1. So a patient is having a poor HCG stimulation response. Then we did anti-Mullerian hormone for our patient, which was 0.5, which is also low for age. So at this point, can we reach a diagnosis? Is this enough for our patient, or we are missing something in our patient? Let's get back to the UK guidance of Society of Endocrinology UK guidance for DSD and revise the algorithm again. We did the standard HCG stimulation test. We are having a low testosterone and low precursor. So the next step is the prolonged HCG stimulation test. And Dr. Noha will give us a hint about the prolonged stimulation test.
What are the indication of the prolonged 3 weeks stimulation test? Is the first indication is the poor response to the short HCG stimulation. If we have a suspicious of absent gonads, especially the patients with abdominal or undetected gonads, and if we have a high suspicious of gonadotrophic hypogonadism, in which the Leydig cells need a more prolonged stimulation to respond. How it is done? As usual, we followed this stimulation by 1,500 units on 2 days per week for the following 2 weeks for a prolonged period of HCG stimulation. And the sample is on day 22. At this point, we expect the prolonged HCG stimulation to have adverse side effects like the behavioral changes in the form of disturbed sleep or persistent crying, some signs of virilization like pubic hair or advancement of the bone age, and on theoretical base, the germ cell apoptosis. And back to our patient for the interpretation.
After doing the long HCG stimulation test for our patient, his total testosterone is 1, which is definitely more than double the pre-stimulation level. DHT was 13 and delta 4 androstenedione was 0.3. So according to what we just learned, our patient is having a good HCG response. So to sum up our patient, he is an infant with bilateral hyperthyroidism, micropenis, 46XY DSD with HCG stimulation test, normal precursors with low anti-Mullerian hormone, low FSH and LH, both basal and post LH or H stimulation with no Mullerian structure. So we finally reach the diagnosis of isolated gonadotropin.
Finally, we want to summarize that short HCG initial test to 2 the test from the undesired added a stimulation test. And
دلوقتي هننتقل للسكند سبيكرز radiological brain imaging for children with growth hormone deficiency. دكتورة رضوى شمة وبروفيسور دكتور شيماء السيد.
السلام عليكم. طبعا في البداية بنحب نشكر دكتورة شيرين على المؤتمر